career. As a newly established position, he was active on the national level as a district governor and was in line to be a national president. When he passed away at an early age, our fraternity viewed this as a true tragedy. The fraternity officers knew that Bill would have remained active throughout his whole life and wanted his legacy to be known for years to come. This is why we named the pre-medical chapter lectureship in memory of Bill. I am honored to introduce our honorary speaker, Dr. Robert Katzer, an emergency physician at the UCI Medical Center. Dr. Katzer graduated from UC Berkeley as a molecular cell biology major and geography minor. He finished medical school at Temple University School of Medicine and obtained his MBA at the University of Irvine. UC Irvine. Through the Healthcare Executive MBA program.
2 buildings over there.
Yeah! Okay, so today he is currently an assistant clinical professor and emergency physician at the UCI Medical Center Emergency Department. Dr. Katzer is also a medical officer with the National Disaster Medical System and also a flight physician. Without further ado, let us all welcome Dr. Robert Katzer.
Great. All right, welcome. So how many people have heard of something called the Patient Protection and Affordable Care Act? Does that sound familiar to anybody? All right, more than I thought. It's normally referred to as what? Obamacare. Apparently, when Obama was writing Obamacare, you weren't allowed to use Obamacare if you were one of the staffers. Until about 6 months to 12 months in, and he decided it's okay to call it Obamacare. I kind of like that now. Also known as the ACA. I'm going to refer to it as the ACA in this talk. And this is, what it is, a brief overview. This is a huge piece of legislation. This will probably be the most defining portion of President Obama's legacy in the U.S. I mean, it won't be Cuba. Cuba's a thing, but this will be the biggest thing when people look back at this. All right, so we're going to go over some parts. Talk about the historical timeline, how you implement the 2,000-page legislation that affects 300 million people. Some components. We're talking about how do you expand it, the expansion of Medicaid, individual mandate requirements, health insurance exchanges, a new way to buy health insurance, accountable care organizations, how you change provider incentives, and then we'll talk a little bit about the debt, right? Because despite the lady 2 elections ago who was on the television saying, get the government out of my Medicare, this is government, right? And the government itself is playing a much greater role as a payer in health insurance than it has ever in the past. And when we're expanding one of those 2 programs, Medicaid, its presence and the effect of this on the debt becomes a much larger thing. All right? A little background. So Medicare is a government-funded insurance, government-funded and administered insurance plan for people that are either of a certain age and that paid into the system when they were paying taxes when they were younger, or that have certain disabilities or renal failure that qualify. Right? Medicaid is a federal funded and administered health insurance plan for people with poverty, disability, and children, historically. All right? So the way I try to remember this is, old people need care, that's Medicare, and impoverished people need aid, Medicaid. That's how I remembered it for years. But they're 2 separate things. Now, in California, no one calls it Medicaid. What's it called in California? What's that? Medi-Cal, right? And that's because each of these Medicaid programs gets divvied up with the states, and there's some state autonomy with those. Where Medicare is a straight federal program, and so the states don't really change how they do that. So that's why in California, Medicaid is called Medi-Cal. And we're going to talk about states' right and Medicaid a little bit longer when we get to one of the 2 Supreme Court cases. All right, so We're at year 6, so this was signed into law in 2010, but a lot of the insurance and other issues had not come into effect initially. So 2010 it was signed, then we got the important things. The tax on tanning salons went in right away. Dependent coverage went from 18 up to 26 years of age for dependents and insurance coverage for people that have policies. Those are the earliest ones. Then in 2011, over-the-counter medicines you no longer could write off. That was one of those early things. Menu labeling, all right? What's menu labeling doing in a health insurance bill? I have no idea is a perfectly reasonable answer to that question. I have no idea. That shows you how government works. Somebody at some table, when they were deciding things, had this idea and they were able to have enough leverage to get it into the bill, right? And that's how the federal government works. So all of you, you live in the US, you're gonna have to understand how our federal government works. It's gonna impact you severely. And that's a very interesting outcome, right? So certain restaurants change, you have a certain number of restaurants, you have to put in nutrition information on your menus as part of the Affordable Care Act, right? Healthcare acquired infections and the iPad, all right? So this is kind of a goodwill item. This saves the government money. This saves the government money. And this is supposed to save the government money, right? Because if you're going to expand coverage and you want to keep the debt manageable, or you want to at least sell it to Congress, right? Because Congress allows spending, you have to cut costs someplace else. And so, you know, we'll kind of see that. So broadly, we're seeing an increase in coverage, more people with insurance, and then we're finding ways for the government to decrease the cost per participant insurance to help keep the budget manageable. All right. In 2012, the Accountable Care Organization incentives came in effect. We'll talk about those later. Insurance info went in terms of transparency. You got an insurance company, you now have to comply with a lot more regulations about what your insurance provides and how you sell your insurance and how you show the public what it has. Value-based payments, fraud and abuse, readmission, that's all cost cutting on the provider end, the hospital end. Closing the donut. What's the donut hole? Anyone know?
So the gap between where Medicare Part D covers, between that and like the cap and catastrophic coverage, right?
Yeah, so we're going to show a graphic, but this is the government again, right? We have a problem where the prescription drug coverage is so complicated that we get for our retired people and so convoluted that they have to draw a picture of a donut to explain all the different areas of cost trouble. And so, you know, this is the federal government, right? So we'll get to that, all right? There was an idea to increase the payment for primary care because primary care may save money. I don't necessarily buy into that. That was a big part of Affordable Care Act, that we're going to get everyone primary care and they're not going to get sick and get expensive, right? So say if you take good of your care of your kidneys and your lungs and your heart and you fight cancer, what's going to happen at the end of the day? What's that? Yes, you will die. But are you going to live a long time or a short time?
Long time.
A long time, right? And so, but that's okay because you'll work until you're 115 and you'll pay taxes, right?
No.
No. Right? You won't, right? And so what happens when people get really old and they get really ill and they have to move into nursing homes? Where does that money come from? It comes from Medicaid. That's where it comes from, right? So I think the math they did with this, and we'll see in the next 30 years, you all be paying taxes and deal with it. But my suspicion is that's a fallacy that they sold a bad deal on that. Tax on medical devices, that means that the medical device lobbyists weren't at those meetings. That's what that means, right? Why do you put tax on medical, right? Right now, Congress has gotten pressure from the medical device lobbyists to remove that. They're getting bills to remove it, right? Again, they call it sausage mazing. That's how the federal government works. And the heavy reduction of disproportionate share hospitals. These are hospitals that have a lot of uninsured people. What happened was if you do a lot of uninsured care, the federal government was paying you money. The federal government said, you know what? Again, cutting costs. They said, we're going to insure everybody, so no one will be uninsured, and we don't need to pay you that money anymore. And we'll find out as this story unfolds that didn't work out exactly as they expected. All right? And then 2014 is a big year. Now we've got expansion of Medicaid. people have to have insurance. That's an individual mandate. The marketplaces for people to buy insurance were launched at a state-by-state business. And then you get subsidies. The insurance company had to deal with new rules. And the employers started to have to provide insurance at a greater level than before. So it took about 4 years of ramping up. We got the easy stuff, the tanning salon tax. We got our menus fixed. And then we got to the hard part of actually expanding insurance and changing how the insurance market works. That's the donut hole. Perfect federal government example of how things work, all right? So you're an elderly person, you have a drug insurance plan. You start buying medication over at this edge of the donut. The first $320 you have to pay for, okay? Then the next $2,930 a year, you pay 20% and the government pays 80%. And then you get to the hole. And then all of a sudden you have to pay 50%. Now, if you're living on Social Security check every year, does that make any sense for your budget? Like if your costs are going up, all of a sudden you have to pay more, right? So they cut a deal, the numbers worked, they signed it and they said a W said it'll be good enough, and that's what they did. So just understand, we got an election coming up, you should understand how the government works. Whatever job you're in will be regulated by the government, so you really have to understand it. As boring as it is, it's so important. That's the donut hole. And then, once you spent $6,700 on medications each year, you're a retired person, then the government calls that catastrophic, and instead of you having paid 50%, right? 50% of $4,000, that's $2,000. Then they cover, I think they cover up like 95%. Right? Now, if you're rationally designing an apple fritter, does that not have a hole in it? You would want this portion just to shrink as you went along, right? That makes sense. Right? As your costs go up, your ability to bear greater costs goes down, so your percentage should drop. All right? All right, so what was the thing? We're going to increase the number of insured people by 32 million people. That's what the forecast was. All right? How are we going to do that? We're going to have an individual mandate. We're going to get people insured because we're going to make them buy insurance. Makes sense, right? What's the best way to get people to do something? You make them do it. Right? We're going to have exchanges so that people can go to a marketplace and they can pick, just like you go to a store and you pick the different product, which is a great idea. We're going to expand Medicaid because a lot of people still can't afford these products based on their annual income. We're going to have some new rules. These health insurance companies, we're going to clean them up. We're going to make a whole bunch of new rules so they're not playing that funny business. All right? And then we're going to transition Medicare from a fee-for-service. What's fee-for-service? You see me, Dr. Katzer, I evaluate you, and I send a bill. My bill is the same whether or not I make the diagnosis right. All right? If you have a lot of different medical problems and you're complicated, my reimbursement goes up more as opposed to you're an 18-year-old UCI student who stubbed their toe on the door. Right? We're going to give you a chunk of money, and if your people do well, if they have fewer surgeries, fewer admissions, you're going to get paid more. That's value-based. Which makes it good for a consumer, right? You're the consumer as a patient, and you're the consumer as what's your other consumer role in government medical insurance?
Taxpayer.
A taxpayer, exactly, right? So it's good for you too. Now, for all of you that are going to doctors, this means you're going to do a lot more jump roping at work. Right? Now, jump roping takes time. There's 24 hours in the day, and at some point, you do so much jump roping that you spend less time doctoring. And I think that's the big challenge. All right? They're going to make these Affordable Care Act. Basically, they looked at Kaiser and they said, we want people to make these things that look like Kaiser. So that's what they set that up. All right? Do some research. Preventative care is going to save us a lot of money. Again, I don't believe that. Class Act was a long-term care insurance plan they're trying to put together. So you could buy insurance so that if you had to be in a nursing home long-term when you got older, you did not have to get poor and then get under Medicaid insurance to get it covered. They gave up on that. It's too expensive. It's expensive. You're living 25 years in a nursing home. That's a lot of cash. All right? And then they're going to have more primary care doctor spots for doctors in training. All right? We're talking just under $1 trillion, good times. But if you're in the private sector, you're like, oh, that's a lot of money. There must be some money to grab there. So maybe, maybe not. All right? If we have to talk about one concept with Affordable Care Act, it's coverage, right? It's getting more people health insurance. Right? Then the tank's like that. So let's talk about insurance. You have money, people paying money to a policy. Things happen under that policy. Money goes out to pay for that coverage. Right? And then for the insurance company, they take whatever money's left over. They can spend the money on the cost of operating, and they keep it for profit. Right? So just as long as you have more dollar signs going in than are going out, the insurance functions. That's general insurance. Right? And one of the things that affect that, right? Are all insurance customers equal? Right? Are they all paying the same amount dollar cents in, or do they all have the same amount of dollars going out? Well, let's consider. You want to sell them a car insurance policy? And when I Googled safe teen driver, this is what I found. That's for the safest young driver. Right? Now, presumably, they would predict that the dollar signs out between these two customers is different. Now, what do they have in common that's concerning in these pictures? No one's looking where the car is going. They're all looking sideways. I don't understand how Britain's safest teen driver can be looking out the window like that. Right? So when you think about health insurance, right, you have people with diseases, and those people are going to have a higher cost. Right? So before the ACA, the insurance companies function like the insurance market would. Right? As an insurance company, we have to stay in business. How do we stay in business? We want to have a lot of people buy our policy. That's put the money in. And we want to make sure that we don't pay out all the money in our coffers because we'll go out of business. How can we do that? We can exclude people that we know are going to be too expensive. If we have a bunch of people with bad diseases like cancer or AIDS, and we know they're going to be very expensive, and we know they can't afford to pay us enough money to cover them, we're going to exclude them on the individual plans. Now, the workaround was for employer coverage, employee-sponsored plans. There was a deal with the large company, the insurance company, that, well, we're going to bring you thousands and thousands of members. Some of those members are going to have cancer. A lot of them aren't. And so you have enough people that aren't going to cost very much to buffer the expensive people. That's the concept of a risk pool. You want a risk pool to be large, and you want to make sure that overall the risk for per person is low enough in all the people that you can afford the expensive people, right? So Vin can still buy car insurance. It's going to cost him a little bit more than Britain's safest teen driver. But there are enough of the Britain's safe teen drivers that he still gets a policy, right? So that's core insurance concept, right? So you exclude the people who have cancer and AIDS, etc. You limit the total number of dollars you can pay out, right? So you say, we're going to pay up to this amount, right? That's how you protect your insurance companies, right? High insurance deductibles. We don't want people to use care they don't need. So we're going to say you have to pay a lot of money up front. Eventually, you're going to spend a lot of money and something's going to happen, like you have appendicitis. And we're going to cover in for that operative cost, etc. Right? So no donut hole here, but actually it works. You pay a deductible and after that you're paying 20% of the total. Waiting period. You can't not have insurance your entire life and then you decide you discovered a tumor yesterday and you're getting health insurance today to get treated, right? Because if everyone thought that way, then there would be no low-cost people in the insurance pool. It would be all expensive people. The expensive people wouldn't pay enough money for their policy, and the insurance company would go out of business, right? These are vilified, but they're all very rational processes of keeping business going. And then adjust the premium for the market, right? The new rules was that you had to do a minimum thing. So you had to do like preventative care, birth control, checkups for free. All right? The government set what the rules are for how much people can spend out of pocket before the company covers it. The government says they have to cover dependents up to age 26. The government said you can't put a total dollar per person, right? You can't take coverage away because someone, unless they committed fraud, because they got cancer, you can't take the coverage away. And you can't kick people out with a pre-existing condition. Does this sound like a good thing for the insurance companies? No, I mean, it's hard, right? They actually set dollar amounts for deductibles, and the periods were weighted for 90 days. All right. Another risk pool example. That guy's going to be expensive in the insurance, right? Before we could block him out unless he's on a big employer plan, right? We just block him out. The government said, no, you got to let him in. Whew. So how are we going to pay for that guy? We're going to get all of their friends, and their friends' friends, and their friends' friends' friends. And we're going to do it by requiring them to buy insurance, right? So we're going to increase the number of members in the pool, and we're going to get the lower risk pool people. Do you think they were buying insurance beforehand? Less likely. I don't get sick. I don't need insurance, right? I'm eating strawberries, right? And grass water, right? What's that from? Healthyeating.org, right? So the only way that all those new government rules works is through the individual mandate. You have to require people to buy it, right? And this is what the government kept saying. We're going to make everyone buy insurance. They're all going to buy insurance. They're all going to buy insurance. Everything's going to be okay for your industry. Everyone will be insured. All right? And for people that don't make that much over the federal poverty line, we're going to give them subsidies so that they have, even though the premium for the plan is that expensive, they won't pay the full premium. The federal government will subsidize it, right? And so that's the whole, if you want to boil the Affordable Care Act into one, this is the major concept of the Affordable Care Act. Right? And then, well, we need to have a marketplace so they can see what they want to buy. And so we also created, each state had to have a marketplace for insurance. The one in California is called?
California Street.
No? Come on, you guys watch TV, billboards. Covered California, right? And the states had the option of building their own exchange. California bought their own exchange, or just to use this federal exchange as a standby. All right, so that will come up in Supreme Court drama later on in the talk, right? It's called Cover California. All right, so we're going to make everyone get insurance. That's going to decrease costs because we're going to improve the risk pool. All right? We're also going to save a lot of money by doing all this stuff. The Congressional Budget Office is a nonpartisan portion of the federal government that crunches all the numbers for everything. When the Republicans are saying it's going to cost this, Democrats are saying it's going to cost this, the Congressional Budget Office says this is what it's going to cost. All right? Better quality, save some money, billion. All right? Cut overpayments, makes doctors work more efficiently. $200 billion, that's a lot of efficiency right there. Making me stay late after my shifts doing paperwork, right? $417 billion. In 20 years, how close do you that thing that's going to be to the rest of it? I don't know. Could be off by $100 billion, could be off by $10 billion. It's so hard to tell. Right? So we expand coverage by making people buy insurance, and we cut costs by making new rules and loopholes and hoops to jump through. Well, which political party did not like Obamacare? The Republicans. But they like it now, right? No, they still don't like it. And so there are a lot of states that have Republican governors or companies that felt that the Affordable Care Act was the federal government doing something they didn't have the power to do. Right? There's a balance of power between what the states can do and what the federal government can do. And so they sued the federal government over it. And what were they saying? Went to the Supreme Court in 2012. There were several different questions. Is the individual mandate constitutional? Can the federal government make you buy health insurance? What are our thoughts on that? Are there other insurance that you have to buy? What insurance do you have to buy?
Car insurance.
Car insurance. Does the federal government make you buy car insurance?
Yes.
How many say yes? How many say no? Okay. A lot of people are unsure, asleep, or not paying attention. Who makes you buy car insurance? What? The states, right? So the states write things, right? And the states can agree. Oh my goodness, they're actually all agreeing. Car insurance is a good idea. Much easier, right? But we can't get all the states to agree that you should have health insurance. And could the government sell this to the insurance company if they say, well, some states will require it, the rest one you'll just get all the sick people and, you know, won't work, all right? So can the federal government do that? The way the Constitution works is if it says in the Constitution that the federal government has power over it, it does. If it doesn't say, the default goes to the states, right? Okay? Medicaid expansion rules. For Medicaid, when states have Medicaid, they get a lot of federal money to pay for Medicaid, and they have to spend some of their money for it, all right? So for years, every state had some rules for who they would cover for Medicaid, right? So the state of California was pretty generous, right? Some states, like in the Deep South, you've got to make like less than $4 a year to qualify for Medicaid, you know? Like you have to be really, really poor, okay? But the states still get funding. The federal government says, you have to cover everybody up to 133% of federal poverty line. Every one of those people in your state has to be covered by Medicaid. You must do this. How can we make you do it? Well, we can't really make you do it. But if you decide not to do it, we're going to take away every stinking cent we've been giving you for your current Medicaid process. So when that got to the Supreme Court, the analogy was the federal government was holding a gun to the state's head and saying, sure, man, you don't have to comply, but it's not going to go well for you. Right? So it was the federal government overstepping its power by coercing states to comply. Anyone, does that not make sense? Raise your hand, because I go over it, right? So bullying, it was bullying by the federal government. Okay? I think normal Supreme Court case, they get like an hour or something. So this was epic. I mean, if it wasn't involved so many just papers and writing and commas, they'd make a movie of it. But it is. Right? 26 states, a couple of people that didn't have insurance. I don't want insurance, man. Federal government's making me get insurance. And a lot of businesses sued. All right? Was California suing? No. Was Texas suing? Absolutely. All right. Individual mandate, right? You got to buy minimum coverage. All right. If you don't pay for insurance, you have to pay a tax on the thing every year. But they didn't call it a tax, they called it a penalty. Why don't they think they called it a tax when they drew this bill through Congress? You can't vote for something that says it has tax? I mean, come on. You can't vote for taxes, so they voted for a penalty. If you don't have insurance, you got to pay a penalty. You pay the penalty with the rest of your taxes, but it's not a tax, it's a penalty. Yes?
Just going off the fact of changing words so that we feel better about it, how did they get everyone to believe that Obamacare was free when it isn't? And like that's legally okay?
Yeah, I don't know why people think it's free.
Yeah.
I often have that conversation when people tell me that they couldn't get the free Obamacare. I was like, the free? I mean, it's insulting to me as a physician. I go to work, right? Right? I'm going to be working the next 2 nights after I go to jury duty tomorrow. When my family's asleep, trying to take care of people, and they're like, well, what? It's not free. I'm like, no, it's not free. Right? 12, 13 years of training to get in that position, a lot of liability, very high stress, dangerous. No, it's not free. So I don't know where that came from. I don't know. It's an interesting question, though. Yeah. All right. So the argument the federal government said was, this is about Congress, or commerce. $938 billion over 10 years. There's an exchange of money. That is commerce. The federal government can regulate commerce, right? It does that, right? It controls what companies can do when they merge, right? So the federal government said, we have the power to regulate that through commerce. All right? The states that sued the government said you do not. It's an overstep of your power. All right? We talked about the expansion and the coercion portion already. All right? So, is the individual mandate constitutional, or is it an overstretch of power of the federal government? Is the Medicaid expansion rules, where if you don't comply, we're going to take away all your money, all your funding, are those constitutional? Those are the two questions. And the third question, which is really interesting, is there's an Anti-Injunction Act from, I believe, the 1800s that requires someone to have to pay a tax before they can dispute the tax as being not fair. And so no one actually paid the tax until 2014. It was 2012. And so the question was, well, if it hasn't been paid, can the Supreme Court even address it? Thankfully, they said they could. All right. Talking about an insurance plan that a presidency is running on that affects hundreds of millions of people. All right. Everyone said they were going to win. I sat and listened to the dean of our law school 2 weeks before the decision came out, talk about his analysis. And typically, before Scalia died, we had a Supreme Court with how many justices? 9 justices. We had 4 kind of conservative, 4 kind of liberal, and then we had Justice Kennedy, and he was always the swing vote. So everyone wanted to know what he was going to do. But what was interesting, at the end of the day, it didn't come down to him. What were the decisions? They could decide now they don't have to wait for the tax or penalty to be paid. All right? They said this penalty is called a penalty, but it's really a tax. It walks like a tax, it quacks like a tax, right? It is a tax. And what are the 2 things that are certain in life? Death and taxes. And no one is disputing the federal government's power to levy taxes, right? So once we established it's a tax, that was an easy question for them to answer. All right? The rules in Medicaid expansion requiring states to expand was coercive, 7-2. Even some of the liberal ones were on that side. All right? All right? And to remedy that, the federal government cannot take away other funds if the state does not choose to expand. This is very important because part of the calculus to cover everyone is that every state would expand their Medicaid. They provide insurance for people that probably couldn't afford to pay for it. All right? But what was the big surprise? It was Chief Roberts. Chief Roberts is rather conservative. No one would imagine that Chief Roberts would vote or rule in favor for the Affordable Care Act. Right? But he said, look, it's a bad law. I'm not evaluating whether it's a good idea, but I can't say the federal government doesn't have the power to levy taxes. I'm sorry, guys. The government can tax. You guys are going to have to deal with the consequences of your poor legislation, but you can collect taxes, so it's not unconstitutional. And so the Affordable Care Act moved on. There was a second smaller one where the states that chose to use the federal exchange, you could build your exchange at the state or use the federal, those states were getting federal subsidies, and you went into the thousands of pages of the law. It said that in the state exchanges, participants could get subsidies. So the argument in that one was, the law doesn't say you can get them on the federal exchanges, so the government is illegally subsidizing millions of people's policies, and they're just like, no, it's the spirit of the law. So that was a much easier one. All right? So ACA is still on course, but 19 states have not expanded their Medicaid. And the problem with this is that the ACA was designed with the assumption that everyone would expand it. All right? So does this mean Americans are less likely to purchase insurance? Yeah, right? Because a lot of them who couldn't afford it are not getting the coverage they thought they would. All right. So you can decide to enter or exit as a state. Right? You get your minimum benefits, and you see your PMD for primary care stuff. You don't have to pay anything. Right? And this expansion of Medicaid up front is a really good deal for the states. The feds are paying 100% in 2014. They're paying 100% of the cost until 2017. It doesn't cost the state a cent. But now we're seeing when you buy a Gillette razor or a printer, then you have to pay for the ink or the razors later. This is going to cost more. And so now the states are going to cover 10% of the cost in 2020. And so we're going to find in 5 to 10 years, we're going to have major budget challenges at the state level for the states that chose to expand. Because they're going to have to pay for a lot of this if they weren't paying for it all. And what's a lot of it? Yeah, 800 million. All right. So of those states that didn't expand, the median level of federal poverty level that is covered is 44%. So 1/3. Right? So everyone more than 44%, up to 138%, they're still too poor to buy insurance, but in that state, they're not covered for Medicaid. So that's another donut hole thing, right? They call that the coverage gap. All right? And the other problem is when they established the marketplaces, because they thought all the people below 138% of federal poverty level would have Medicaid, all these people aren't making enough to get any federal subsidies when they try to buy on the marketplace. So people that make more money than them will get a federal subsidy, but they won't. And so they are really getting hit hard there, this group. So you're a state governor, you want to expand, not expand. What's the downside? Well, right now, thousands of people are getting insurance that the federal government's going to pay every cent for. So as a governor, that's kind of hard to answer for your populace, right? And that's millions of federal dollars that's going to improve your economy, right? That's just money coming into the state, right? So that's the downside. The upside is like if you're a Republican governor in a Republican state, you're going to say, yeah, stick it to Obama. All right, we're all going to be uninsured, we're going to have suffering people, they're poor, but man, we are showing Obama we're not going to play that thing, right? You can insert state autonomy. But the other thing that we're going to learn about in the next 5, 10 years is when that bill comes due to the other states, these states are going to be they're not going to be hit with this big of a cost. And we're going to see how that unfolds. Not a lot of people have written about that. All right, so qualified legal residents have to buy insurance. If you don't, you have to pay this total amount, which goes up to $2,000 or a certain percentage of your salary, 1%, 1.5%, 2.5% in 2016 on, up to a maximum of $12,420. The amount you have to pay depends on how many children you have. The Empire does not care about your stick-figure family, but the IRS does. And not coincidentally, this number is based on the cost of the cheapest insurance policy. They're like, basically, you're going to have to pay the amount it will cost to insure your family, so you might as well buy the insurance. Pretty good insurance, pretty good system, I'd say. All right. So what do the employers have to do? They have to, and they're more likely to have to provide coverage to their employees than before ACA. And they have to pay penalties if they don't. Health exchange we talked about, there are marketplaces to buy. Calvert, California is already on the internet and kind of look, hey, I want to see what it's like to buy health insurance. Maybe I don't like SHIP. Isn't it SHIP? Is that what the UC's plan was? I think it was called with UC, yeah. Maybe I'll buy another plan, I just won the lottery, got some extra cash. You can poke around, see what it costs, see what the choices are. All right? Undocumented or illegal residents can't get insurance. The state of California is in the process of voting through a way that the state may cover health care for undocumented immigrants in the next year or two. So that will be another issue with the budget. And it may have a lot of different consequences, good and negative. You could build your own. Most states just let the federal exchange, which that's what I do. Just let, why spend all that money in your own state exchange? All right. So, the government says if you're selling health insurance, it has to meet these criteria. It needs to have the bronze, silver, gold, platinum, or catastrophic. all right? And then for people that don't make very much, 133%, 300%, we're going to provide subsidies for it. So your bronze plans, the premium cost is less money every month, but it only costs 60%, it only covers 60%. So when you actually spend money, you're going to have to pay 40% of the bill, all right? So if you don't use any health care, bronze is the cheapest. If you don't anticipate, right? And then it goes up to platinum, where your premium every month is the most expensive, but every time you use healthcare, you only have to pay 10% of the bill, and the insurance company picks up the other 90%. Right? How much you pay out of pocket, this is health savings account, is the same amount for how much you can stow away health savings. That saves you a little bit of money in income taxes when you're making money. All right? And for catastrophic, most people aren't eligible for that. There's no essential benefits. Right? Now the problem with this in the health insurance industry is when you tell an industry that these are the exact things for everyone's plan, it's really hard for each company to differentiate, right? So what's really the only way they can differentiate themselves from the other plans? If everyone has the same components that have to work the same way. How do you move customers? Commodities. What are commodities based on? They're all the same thing, so the only thing that matters to the marketplace is the price, right? And so we'll see in the next 5 years whether or not this is a good thing. For someone going to the exchange and trying to buy insurance, it allows them to see what each plan has, so they're not so confused. But if you have a bunch of insurance companies just competing solely on price, and they're not innovating, they're not delivering a particular service for you that works for you and your health needs, it may take away a little bit. All right, accountable care organizations, think Kaiser. If you have a bunch of hospitals and doctors and clinics, and you take care of patients and you find a way to take care of a patient that costs less money, they have less complications, surgeries, in the hospital less time. The federal government says, if you save X amount of money in your bills, we're going to give you part of it and we'll keep part of it. It's a savings plan, all right? And so that's part of decreasing costs. I think this is good because the system's very fragmented, right? And there's a lot of waste, right? And then now for the providers, for physicians and hospitals, the federal government's going to change how it pays. It's going to be more value-based. IPAB, this is known as death panels. Right. This is interesting. This is a group that's supposed to save money in Medicare, but they can't rational care, they can't increase revenue, and they can't change benefits. They think they're going to save $23 billion over 10 years. Unless they're negotiating on drug prices, I don't know where that $23 billion is going to come, based on the fact that they can't decrease what you're providing. So, it's 2016, we've had the markets going for about 2 years now. We're 6 years into the bill. And how has this changed the number of coverage in the US? Over this period, we're going February, basically 2013 to 2015, 23 million people got insurance that didn't have it before. 6 million people lost insurance, all right? Of those that got it, 9.6 is the largest employer base. So we're having more employers cover you. That's what part of that. And part of that is as people get their first jobs with the company, they're going to be newly insured, right? 6.5 million were part of the Medicaid expansion. But another 6 million were people that used to have employer base, lost it, and moved into Medicaid. And so what this means for us is now the proportion of people on Medicaid has gone up. And as a physician, what's the bad thing about Medicaid? There's a lot of paperwork and they pay you very little. A lot of times they pay you less than your hourly operating costs in your office. So a lot of physicians won't accept Medicaid. So you have a whole bunch of people with coverage, they have a card, insurance, but they can't find a provider who has a financial incentive to see them. I have to see everybody, so it's easy for the ED. But for, you want to see like a GI doctor, some like, specialist with a nice office that does procedures, that's a lot harder. And so that's going to be 12 of your 22 million. And I think that's a lot bigger than they thought. We're going to have to see how that happens. That affects the market. What do people think over time? Back in 2010, all right? These are the I don't like, and these are the I like, all right? Right now, we're about in the like and not like where we were 6 years ago. So it hasn't really changed. It zigs and zags. Okay? All right. Get rid of the, repeal it, 16%, and do nothing. All right. Repeal it and put a Republican thing. Although the Republicans really haven't come up with a plan, so I don't know what that would be. That's 13%. Right. The majority of the people say, hey, the ACA is pretty good. We need to make it better, but it's pretty good. We shouldn't just go back and repeal it. All right. And then a quarter of the people saying everyone should have health insurance in the country. And that's interesting. I don't think we saw 25% of the population in terms of voices when this was going out in favor of universal coverage. All right? And then, this is, Democrats like it more, Republicans like it less. All right? Not rocket surgery, it's pretty straightforward. All right? And then we're going to talk just in summary about the debt, because this is what it comes down to, right? Our government is the world's largest health insurance company with a private army. If you look at federal spending, that's what it is. It's insurance and military spending. Right? Those are the two largest items in our budget. Right? This looks at federal debt as a percentage of gross domestic product. So that's a way to take as money, money is inflation, to look at it. Basically, during wars, it spikes, it spikes. It spiked during the great, American Reinvestment Act, during the Great Recession. And now our economy is not growing so fast, so we're going to have to see where it goes. I don't think that these people are correct with this Everest peak. I hope not. But it's probably not going to shoot down. And we've got an aging country. All right. So as this goes up, the millions of people in that 65 to 74 are going to go up a lot. Some of those people have to work because they didn't make enough or didn't save enough. But a lot of them aren't working. And a lot of them have chronic medical illnesses, and so they're going to spend a lot on health care. And we're going to have some way to fund that as a country. And then if you look at different components, non-interest spending, major health care programs. So health care programs have been going up. Social Security has been fairly stable, not too bad, especially considering the demographics gone up. And so we'll see if those protections lean up. And then just looking at Medicaid, Medicare, and Social Security as percentages of GDP. Social Security is not the big challenge. Right? We're seeing Medicare quadruple, and Medicaid, 6, 7 times as much. Right? And so for the people that say get government out of Medicare, this is it. The government is running health insurance in the foreseeable future in the U.S., for better or for worse. And so it's important to know how it works. All right? And with that, thank you. Any questions? Yes.
So how does the ACA affect the practice of emergency medicine, in regards to patient loads and letter compensation?
Great. How many of you have been in the ER this year as a patient? Did any of you go 5 years ago as well, or several years ago to compare? Is it busier or less busy? Like you sit around 8 hours and the doctor never sees you busy, right? Busier, right? And so when we talk about coverage and access, right? What was the major one core concept of the Affordable Care Act? Coverage. And the whole premise is that if we could just take care of coverage, everything else will fall into line. Where does that not work? It doesn't work where your coverage is providing a payment that is less than the overhead costs of the business. And so those patients don't have access to the doctors. But where do they have access to? Emergency departments. And it makes sense and it's good, especially for people who don't have a lot of financial means, that they're not going to require to pay a lot to get emergency services, which I think is really good in the government, right? You want, when people have an emergency, you want them to feel comfortable going to get care, right? So they can't see a normal doctor because they can't find one. It's too confusing. And their cost sharing in the emergency department is low. So the system, any rational person will make that decision to go to the emergency department for care. And so that's where a lot of the patients are going. And so volumes have been increasing. And that's really how it's affected from a volume standpoint. Now, the Affordable Care Act, from a practice, any provider in a health system, there are a lot more rules, all the value-based care, patient satisfaction scores, revenue. There are a lot of new things that we have to figure out as doctors every day we go to work. What I have to do for the federal government so I get paid for the work I'm doing to try to take care of patients. And how do I make sure I'm not taking away too much of my patient care time to meet the needs of the government? I think those are the big changes.
Was there another question, or was that? And the second part of that was, how does it alter the provider compensation as far as emergency medicine versus just any other private?
Yeah. Well, in theory, it would decrease the number of patients that don't have insurance and see you. Although you saw that a lot of populations are left out, especially the undocumented population, and so there's still a large amount of patients with that. And for someone who works in a health system, because the government set rules and they don't want to pay for readmissions within 30 days from like heart failure issues. So how you kind of respond to a patient in a situation may change based on what the government's dictating. So there's a little bit of nudging in the government in a lot of different areas. And then it's just volume, you know? And you're seeing a volume of patients that, because they can't get to normal doctors, the types of complaints they have are not what you may always consider the emergency complaint. But we deal with everything, that's our job. And you know, that's not new to us. It's just a proportion of our work that may change over time.
So when did the court case take place, the Supreme Court?
The first one, with the Roberts swing vote, that was in 2012.
Okay.
Yeah. And the second one was the exchange one, was just this summer, 2015.
So which one was the coercion?
That was the 2012 one. That was really the big one. The 2015 was like, it was like a last ditch effort to find something. I mean, they're like, you know, oh, there's a comma missing in the law, we just use, I mean, but the first one was like a legitimate case.
Right. So it's been 4 years since then. Like, have they come up with any kind of new policies to address like the coverage gap? I mean, I think they added more.
Look, the federal government is operating on a continuing resolution. Look that, Google that. They can't even, like their budgets are set up, so we can agree to keep the money flowing, but we can't agree on what to fund it. So each part of the government can't change what they did from last year. I mean, Congress cannot do anything right now. That's why they approve it, you know? And there's no way they'll be able to push that through, you know? So that's the thing, right? So how do we best deal with that? I don't know, you know? And now everything, what's going on right now? I mean, it's a presidential election. You know, right now everyone's just trying to figure out who's going to be sitting in the big chair next year. You know, so Congress is not exactly trying to push policy right now. Yes.
What's going to happen to Obamacare if the Republican wins in 2016?
I think that Obamacare has been to the Supreme Court twice. We've expanded coverage for 30 million people over 6 years. It's really hard to take away entitlement systems, historically, if you look at them. So I think at this point, they're not going to be able to repeal it. I think the question is, what's ACA v 2.0 going to look like? Like, what's the next step in the evolution? That's what I really think. You know, they voted to repeal it more than 50 times now. A lot of that's like political, political posture. So I think it's going to be here to stay. It's a question of how do we make it better, how do we live with it, as patients, as taxpayers, and as people that work in the healthcare system.
So what type of changes would new healthcare providers like less inclined to go to school expect in the practice of medicine as a result of the ACA for the next 5 years?
Yeah. So patient satisfaction survey results are having, the government says up to 20% of what they pay you is based on your hospital patient satisfaction, whether the patients are happy. So that's been like a customer service thing that was pushed by Obama under ACA. And these value-based cares requirements really change how you get paid and what's expected of you to get paid. So there's a lot, and it's hard to keep up with it. With new year, every year you have some new thing. You go, oh, we got to learn about this to get paid to do our job. It's a big challenge, and I think, and then I think you also are seeing a consolidation. So if you're a physician, you're even more likely to work for a company as an employer, as an employee, than before ACA, where you may have leased a medical office in a place and a good practice, and you ran a small business. That's much less likely. We're seeing a lot of consolidation. And the ACA is driving these accountable care organizations, like big ones. Here at St. Joe's House, you think of like Mayo Clinic, you think of Kaiser Permanente, Geisinger, those different companies. So you're more likely to be a doctor that works for a company. And that's just a different, you know? It's a whole kind of different beast. Yeah.
Just based on how doctors reimburse by the patients, how the patients score them in the transaction surveys, because of HCAP specifically.
Yeah, so that's one of them, absolutely, yeah.
Will this affect how a doctor prescribes?
Absolutely, yeah. So there's excellent data. There's excellent data that patient care, patient satisfaction score adjust, provide. Yeah, it's an interesting study. I don't know how good it is, but I know it's out there, right? So for anyone that watches House MD, you're like, of course, right? That guy's a jerk, but he does a good job, right? I don't know, you know? You show up to work every day, you deal with what they throw you, and you try to figure it out, and you try to find ways to still take care of the patients. All right, thank you very much.
Who here is pursuing a career in healthcare, politics, or business? So a lot of us. So this lecture has been so helpful for helping us to have a better understanding as to what we're working towards. So we're really thankful for this lecture, and we all learned lots, right guys? Yeah. All right, so on behalf of PhiDE International, we have a plaque to honor you for all your inspiration and wisdom, and also an honorary check of $100. Dr. Katzer has been so nice to offer 6 one-on-one meetings, and so we had a raffle going around that was $1 each.
How do you know I won?
I'm
just kidding.
Over there. So,
I took the whole roll.
yeah, we're gonna see who those 6 winners are. Any last minute? Yeah, over here. You can Venmo. Yeah.
Last chance.
Before we do the raffle, yeah, one second. I just want to thank Dr. Katzer again for coming out and speaking to us, and I also want to thank Gelfand Committee and also my business committee for coming out of this past couple of days. It's been a really hectic couple of days, but you guys pulled it off, and we've had some awesome events. And especially want to thank Kristen. Your 2 littles are so proud of you, and they see how much work you put into this week, and they just want to get you. And they're sorry to and they love you very much. Thank you. Yeah, I just wanted to also recognize everyone who helped out. It really wasn't a one-woman show. Like, a lot of the e-board really helped me out. I worked really closely with the president, secretary, programming, VPF, everyone, chair board members, all the members. It's just amazing how PhiDE really came together to make March Madness happen. And I hope the tradition just keeps growing and getting better and better. So thank you guys so much.